Good afternoon, everyone, and thank you for joining today's presentation, Facts and Fiction, What Do We Know About E-Cigarettes? And now our featured presentation, Facts and Fiction, What Do We Know About E-Cigarettes? This presentation is brought to you by the National Center for Primary Care at Morehouse School of Medicine in partnerships with the Centers for Disease Control and Prevention's Tips from Former Smokers campaign. You can learn more about the National Center for Primary Care by visiting www.primarycarematters.org. You can also follow us on Twitter at @PriCareMatters. So just a little bit about the NCPC. The National Center for Primary Care is a national resource for encouraging doctors to pursue primary care careers, for making primary care or practice more effective, and for supporting primary care professionals serving in underserved areas with a focus on access, effectiveness, and equity. A little bit about the TIPS campaign. The TIPS campaign was the first federally funded national tobacco education campaign launched in March 2012 by the Centers for Disease Control and Prevention. The TIPS campaign profiles real people living with serious long-term health effects from smoking and secondhand smoke exposure. Today's webinar objectives. We want to first analyze any early findings of the health implications and research associated with e-cigarettes. Also to analyze the national trends of recent e-cigarette recommendations regarding short-term and long-term use, and also to critique the potential impact of e-cigarettes on the delivery care system in years to come and whether it's going to take the same path on healthcare as cigarettes. And now I'd like to introduce our presenters for today, Dr. Brian King, Deputy Director for Research Translation at the CDC's Office on Smoking and Health, and Dr. Ann Gagliotti, Assistant Professor of Family Medicine at the National Center for Primary Care at Morehouse School of Medicine, and she'll serve as today's moderator. Now I'd like to turn it over to Dr. Gagliotti to get us started with a quick polling question and introduce our featured speaker.
Thank you very much, Tabitha. I would like everyone to participate in the first polling question. And the question is, do you currently treat someone who uses e-cigarettes? As I was speaking with Tabitha about this question, I was thinking that it really probably matters how we screen for tobacco use in our practice, and whether we are specifically screening for e-cigarette use versus conventional cigarette use. And I'm not sure that we are doing that consistently across primary care practice, as there are some limited guidelines about the actual implementation of that. So I'm excited to hear more about what's going on the cutting edge of this research from our speaker, Dr. Brian King, who is not only an expert in the field of tobacco use research, but is certainly one of the nation's leading experts on e-cigarettes.
Okay, wonderful. Thank you for the introduction. Today I'm going to be speaking about the e-cigarette phenomenon, which is certainly the topic du jour in tobacco control, and there's been a lot of questions related to what the potential public health benefit or harm these products could have, both at the individual level as well as the broader population level. So today I'm just going to walk through some basics with regard to what these products are, what we currently know about in terms of the science, particularly the context of what the potential harms are for youth, as well as any potential benefits that can arise from adult smokers who use these products. And then I'll end with some discussion of the population-based strategies to address the issue of e-cigarettes. And the underpinning theme is really that we still don't know a lot about these products, but we do know enough to act to implement common sense interventions to mitigate any potential harms and maximize any potential benefits at the population level. So with that, I'm going to start with just an overview of what e-cigarettes are and what the landscape is. There's a lot of different terminology that have been used with regard to these products. They hit the United States in about 2007. Although there have been precursors of these products back to the 90s that really didn't pick up. They were called the clips, and they were electronic products, but it wasn't until the new variation of the e-cigarette came into the United States around 2007 that we started to see upticks in use, primarily around 2010, 2011. They're known by a variety of different terminologies. Aside from e-cigarettes, you've probably heard vape pen or e-hookah or hookah pen. And the more scientifically stuffy term is electronic nicotine delivery systems, but that's typically used in a more scientific circles as opposed to the more generalized e-cigarettes. But really, regardless of what you use to refer to these products, they really have a similar structure in terms of the main types of these products. And those are included at the top of this slide. And I'll work from left to right. So on the far left, you have the mini e-cigarette, and this is also a disposable variety. And so you'll see these at convenience stores and gas stations. And the people who first start with e-cigarettes, this is typically the primary product that they use. And then people tend to graduate towards the larger systems. And so these disposable varieties are the same size and shape as a regular cigarette. And once the user depletes the liquid, they throw it out and discard it. The next is the mid-size, and that's in the middle. And these are the ones typically referred to as vape pens or hookah pens. And these give the user a little bit more latitude to modify the constituents. So they recharge the device itself, but they replace the liquid cartridge, which can include a certain nicotine concentration or a flavor of their preference. The one on the far right is the largest and the one that gives the user the most latitude to customize it to their preferences, and that's the mod or the tank spout system. And these are the kind you're going to see at a vape shop. The more experienced users typically buy these. These are the ones that you can also do some fancy tricks with, and also can be used to accommodate other psychoactive substances such as THC, among others. And so these larger modified systems are primarily ones that the people who are quitting using e-cigarettes are using these devices. So regardless of the major three types, the general anatomy, if you will, of an e-cigarette is really the same, and that's the bottom portion of this slide. And so you see that they all have a battery, right, because it's an electronic device, so you need a power source. They also have an atomizer, which is the heating element, which produces the aerosol, and then they all have a liquid cartridge, which contains the actual liquid, which is aerosolized. And you'll note that I use the term aerosol. Frequently we use or hear the term vapor, and people even call themselves vapors who use these products, but there's actually a misnomer. We know that it is not a water vapor, which has a positive connotation, that it's seemingly harmless, but we know, in fact, through toxicologic research, that it is, in fact, an aerosol and can include harmful and potentially harmful constituents. And so I'll touch on that in some of the later slides, but you'll note that CDC, as well as other public health agencies, use that term aerosol because we don't want to perpetuate that misperception that what's emitted from these products is harmless water vapor. So this next slide harkens back to the 2014 Surgeon General's report, which was the 50th anniversary report on tobacco use in this country. The first, of course, was released back in 1965. And at the time, we were still learning a lot about e-cigarettes. So there wasn't any major conclusions about it in the 2014 Surgeon General's report, but we really set the stage for the theoreticals of what could happen to the tobacco product landscape as a result of the introduction of e-cigarettes. And essentially what was acknowledged by the Surgeon General at that time was that there could be public health harm or there could be public health benefit, particularly in the context of how e-cigarettes, particularly conventional cigarette smokers, use these products and how it could impact the use of conventional cigarette smoking, which of course we know that combustible tobacco use, including cigarette smoking, is the overwhelming cause and burden of tobacco-related disease and death in this country. And so combustibles remain public enemy number one, but it's to be seen about what the impact of e-cigarettes could be in terms of increasing use, particularly among kids, or potentially decreasing use as a result of cessation. So in terms of the benefits, I'll start with that, and it's important to acknowledge that there are potential benefits to e-cigarettes, and potential is the key qualifier here. These are theoretical benefits, not necessarily what's being realized in the population, but it's important to acknowledge that e-cigarettes could have an inherent benefit at the individual population level. And that's because e-cigarettes do not contain nearly the same harmful constituents as cigarette smoke, which is about 7,000 chemicals and 70 carcinogens. So they are safer than conventional cigarette smoke, but that doesn't mean that they are safe. And so this puts the discussion on the harm continuum and what the potential impact could be. That being said, these are the scenarios at the individual and population level where you would have a net public health benefit. And this really gets at the issue of if a conventional cigarette smoker were to quit completely and transition to e-cigarettes exclusively, there would be a net benefit for the individual. That being said, that's not necessarily what we're seeing. In the cross-sectional studies that have been conducted, we see that most of the e-cigarette users continue to use conventional cigarettes, and that's what we call dual use. That's at about 60% among all adults, and we see the rates increase with increasing age. And it's important to note that continuing to use both products doesn't yield a significant health benefit as if you were to just quit completely and transition. So merely cutting back the number of cigarettes you smoke is not enough to fully reduce tobacco-related disease risk. And even smoking a few cigarettes per day can double risk for coronary outcomes as well as other adverse health effects. So it's really important in terms of messaging to acknowledge that there could be a net benefit, but that's if someone were to transition completely and exclusively to e-cigarettes. And so in terms of the next step of assessing this issue of cessation, there have been longitudinal studies and cohort studies that have followed the same smokers over time to assess the impact of e-cigarettes in terms of cessation. And the bottom line from those studies is the science is mixed. We do know that anecdotally some people are quitting, and that's a good thing. But the bottom line is the plural of anecdote is not data. And right now the data that we have, particularly from the robust longitude randomized trials that have been conducted, do not demonstrate long-term efficacy of e-cigarettes as being a useful cessation tool from conventional cigarettes. That is not to say that we may not have that science in the future. FDA and others are doing some very key research, longitudinal work, including the PATH study that should glean some answers. But currently the rating for the efficacy is low by grade standards for various entities that rank this, the USPSTF in particular. And a Cochrane review also has identified the evidence to not be sufficient to determine the efficacy of these products for cessation. So the jury is still out, but we're hopeful that there will be further science moving forward. Some of the initial trials in Europe have found that people who use the larger tank-style systems, remember from a first slide I showed, have higher efficacy in terms of quitting, and that's likely because those products afford higher nicotine yield. So it's enough for them to wane off of conventional cigarettes, which typically produce about 1 milligram of nicotine yield to the individual user. So you need enough in the e-cigarette to successfully wane the individual off of conventionals. So on balance, there are also several population harms as well as individual harms that could result from the use of e-cigarettes. And this is really important for us to balance what the net health impact of these products will be. And so here are some of the potential harms that could be realized and some that have actually already been realized. So I'll go again from left to right. The first is if these products lead to initiation of combustible tobacco use among non-smokers, particularly children. We have seen about a half dozen studies that have been conducted to date, longitudinal, that show that kids who use e-cigarettes are significantly more likely to use regular cigarettes in the future compared to those who are not. Of course, there's still some limitations in generalizability of these studies, but they are pointing in one direction in terms of increased odds, from about 2 to 8-fold increased odds of use of cigarettes in the future among e-cigarette users. There's also concerns about lead to relapse among former smokers, and also concerns that they could diminish the chances that a smoker will quit or discourage them from using proven quit methods. Again, we have decades of science demonstrating the efficacy of nicotine replacement therapy and other cessation medications, and FDA has 7 approved medications. But in terms of the efficacy of e-cigarettes, the science is not there, and there's concern that e-cigarettes could be used as a tool for cessation when the efficacy is not proven, as opposed to these interventions that we know work and can increase the likelihood that someone will be successful. There's also concerns over exposure to the aerosol, the secondhand aerosol, which the Surgeon General's report that was released in 2016 noted was not harmless, and particularly to vulnerable populations such as pregnant women and children, given the nicotine concentrations that are in the aerosol. There's also concern about glamorization or renormalization of tobacco use. E-cigarettes can be legally advertised through a variety of mechanisms, including television, for which conventional cigarette advertising has been banned for nearly 40 years. And so we're seeing a lot of variety of advertising for these products, particularly to kids, and using novel methods of media that aren't otherwise used for other tobacco products, including the internet as well as the television ad. And then finally, there's concerns over poisonings among users and non-users. We've seen skyrocketing rates of calls to poison control centers nationally with regard to exposures to not only the liquid for users, but also dermal contact and ingestion among children. We know that an increase in call volume was from about a handful per month in 2010 to an excess of 400 per month in 2014, and about 50% of those calls were for children less than 5 years of age. And we have had several deaths that have occurred nationally, including one child in upstate New York who ingested the liquid and died, as well as someone who committed suicide by injecting the liquid directly into their bloodstream. So in terms of the concentration of the aerosol, it's important to know that it's dependent on the product itself. And there's a wide variety of these different products that are available on the landscape, and they were only recently regulated by the FDA. And that went into effect of August of last year. So it was a wild, wild west for a very long time. And it's actually still very much so a wild, wild west. But we do know that the preponderance of the data shows that overall, regardless of the product, the aerosol is not harmless. And it can contain harmful and potentially harmful constituents, including nicotine, which is prominent in the vast majority of these products. And as the Surgeon General's report in 2016, which was released in December, noted, nicotine exposure during adolescence can cause addiction and can harm the developing adolescent brain. So that youth angle is particularly important in terms of messaging, and that is why that was the focus of this Surgeon General's report. And we know from the existing science that about 9 out of 10 adult tobacco users first begin before the age of 18. So prevention is really key when we talk about tobacco control, and we wouldn't expect it to be any different for e-cigarettes than for any other types of tobacco products. And so with that, we're going to open it up to a poll now that we're talking about kids. And the question is, more teens now use e-cigarettes than conventional cigarettes. Is it a true or false? So we'll give you a little bit of time to ring in your answers. And I will say that we've been assessing youth use of e-cigarettes since about 2011 nationally, and several states have included questions on their population-based surveys as well. So we have about a little over a half decade's worth of data now on this issue, which has been really helpful for informing tobacco control policy and practice. And I'll note that the landscape continues to diversify. So e-cigarettes are certainly not the first novel product to hit the landscape, and they most likely will not be the last, as we see new products such as heat-not-burn technology, among others, that have entered into the U.S. marketplace. And the tobacco industry is very adept at creating new fanangled devices to entice the population, particularly kids. So these will certainly not be the last. So with that, it looks like our results, we've got about 93% say that's true and about 7% false. And the truth have it, that is actually the correct answer. It is true. The most recent data from 2015 show that about 16% of youth nationally use e-cigarettes, and that's compared to about 9% among for cigarette smoking among youth. So it is the most commonly used tobacco product among youth in the United States, and it surpassed conventional cigarette smoking in 2014. And that has persisted in 2015, and the more recent data from 2016 should be coming out soon. But e-cigarettes are the most commonly used tobacco product among youth. And for those who are questioning why we call it a tobacco product, that's because of the way that it's regulated in the United States. And e-cigarettes that contain nicotine derived from tobacco, which is essentially the majority of nicotine on the market, are regulated as tobacco products in this country. Okay, so with that, speaking of nicotine, I think this is something important to acknowledge in the context of youth and young adults, and this got a lot of attention in the Surgeon General's report. And there's currently a public service announcement with Dr. Vivek Murthy, our Surgeon General, speaking to this issue of the harms of nicotine on youth. And so the major conclusions from the Surgeon General's report was that exposure to nicotine during adolescence can cause addiction and can harm the developing adolescent brain. There's also harms related to fetal toxicity for pregnant women in terms of nicotine exposure at various doses. And then also ingestion of e-cigarette liquids containing nicotine can accuse acute toxicity and possibly death if the content of the refill cartridges or bottles containing nicotine are consumed. And so these are really critical conclusions of that Surgeon General's report, which are founded on several decades of science in terms of the fact that nicotine is not necessarily risk-free. We certainly know that we use it in nicotine replacement therapy and patches through a regulated dose, but for youth and pregnant women in particular, there are inherent risks of these products. So in terms of what we can do, this is the biggest question for public health. We know that there are inherent risks for e-cigarettes, particularly for youth and young adults. So what's the solution? And this is tobacco control vaccine, as I like to call it. And this is really founded on the fact that people like a quick fix in the United States, and we have a lot of discourse around controlling things, tobacco control. But we don't talk as much about prevention. And prevention is really key in the context of tobacco control. And much like we have efforts to vaccinate our children and others to prevent disease, the same goes for tobacco. And so this is kind of a broader level population-based tobacco control vaccine that if you want to prevent tobacco-related disease and death, there's a lot you can do on the front end. And we know that prevention is a hell of a lot cheaper than treatment. And that same goes for tobacco control. And things like increasing tobacco product price, smoke-free policies, and hard-hitting media campaigns in coordination with enhanced cessation access are going to get you that population-based prevention. Because again, remember that 9 out of 10 tobacco users begin before age 18, and 99% begin before age 26. So if you can hit that youth, young adult demographic, you're preventing a future generation of tobacco and nicotine-addicted adults. And so this was founded in the major conclusion of the Surgeon General's report in 2016 that really acknowledged the fact that there are actions that can be taken to address e-cigarettes, and particularly among youth and young adults, and it's these proven interventions that we already know work. We just need to modernize them to include the diversity of tobacco products. And that being said, there's a lot of stakeholders who can take action, and you can see several of these listed. The Surgeon General did call them out in the report, and that even included e-cigarette manufacturers and distributors and retailers. They even play a role as well. There is a way to responsibly advertise products. We see that for nicotine replacement therapy all the time, that it's very empowering and promoting cessation. That's not necessarily what we're seeing for e-cigarettes. We're seeing a lot of glamorization and sex and rebellion among others that are really promoting the use of these products, particularly among youth. But pertinence to this crowd, stakeholders who can take action includes clinicians as well as public health care professionals, and so that was called out specifically in the report, and there is a major conclusion noting the importance of clinicians for educating youth and young adults in particular about the harms of e-cigarette use, as well as speaking to patients who are trying to use these products to quit, to give them the most recent science and evidence-based interventions to inform that effort. So with that, I'll also say that there are some resources for clinicians currently available. Of course, CDC's TIPS campaign has a plethora of resources for conventional cigarette smoking, as well as resources related to dual use of e-cigarettes and conventional cigarettes, including some helpful tips for clinicians. And the most recent Surgeon General's report, we released an interactive website that includes information on e-cigarettes in young people, and there is actually a healthcare provider card that can be used with specific questions that have been asked and how you could answer those in the context of youth and young adults, and also provides a nice fact sheet summary of the existing evidence on the potential harms of e-cigarettes among youth and young adults. So with that, I'll end with my summary slide, and this is the key takeaway message. So if you've fallen asleep, you can rise from your slumber, earn that CME credit. Here we go. These are the major bullets of the previous content that I've presented. We know e-cigarettes are now the most commonly used tobacco product among U.S. youth. That occurred as of 2014. 16% U.S. youth use these products. Youth use of tobacco products in any form, including e-cigarettes, is unsafe. So the bottom line is kids shouldn't be using any type of tobacco product, irrespective of whether it's combustible, non-combustible, electronic, particularly given the vast majority of these products contain nicotine, which can be addictive and can harm the developing adolescent brain. In terms of cessation, adults must quit smoking completely to realize potential benefits of e-cigarettes. However, currently e-cigarettes are not currently an FDA-approved quit aid, and there's no conclusive scientific evidence that these products are effective for cessation. We do know that some people are quitting, and that's a good thing, but it's only those using certain type of products, and the science is still variable in terms of long-term efficacy of quitting. We also know that the tobacco product landscape continues to diversify, and it's critical to modernize our strategies to adapt to these changes. So things like pricing strategies to increase the price of e-cigarettes to prevent kids from getting them, youth access restrictions so they can't purchase them anywhere they please, including e-cigarettes and smoke-free policies so people aren't exposed to the aerosol that's emitted to these products, and both indoor areas of public places as well as smoke-free home rules that include e-cigarettes so people aren't exposed to the aerosol. There's a variety of common sense strategies that can be done to mitigate potential harms while also potentially maximizing benefits that could be realized by adult smokers. And finally, there's multiple folks that can take action. There's multiple stakeholders, and that stresses the diversity of the populace, including government officials and public health officials, but also clinicians and those at the individual level. And so with that, I will end with my contact information. I have a very famous email, baking@cdc.gov. You get a lot of interesting email on salmonella and cookie dough, among many other things. And so I'm happy to answer any questions through my staff here in CDC's Office on Smoking and Health. We have over 150 staff that address a diversity of issues on all types of tobacco products with many resources that extend beyond e-cigarettes. So I'd encourage you to check out our website for information on tobacco product use in general, and there's some good resources there for clinicians that address not only the novel products, but also those products that have been around for several decades. So with that, I believe we're going to open it up for our moderated discussion and question and answer, which I hope will prove fruitful.
Thank you so much, Dr. King. That was a fantastic presentation. I would invite participants who are on the line to type in any questions that they might have in the Q&A box, and I will field those to Dr. King. But in the meantime, I do have some questions that were submitted ahead of time that I'm happy to ask. There were some specific questions about patients with severe persistent mental illness and the use of e-cigarettes. Is there any particular work being done on patients with mental illness and their use of e-cigarettes, Dr. King?
Yeah, so this is a really critical area, and particularly for tobacco use. We know that about 40% of the cigarettes consumed in the United States are among those with mental illness, and so there's certainly several comorbidities as well that complicate the treatment of tobacco use in general. But in terms of the e-cigarette phenomenon, we don't have the data yet, but the good news is that there are efforts underway by various entities to start conducting this type of research. One of the primary limiting factors has been getting the e-cigarette related questions on existing surveys so that we can assess this population in particular. And so there's a lot of efforts underway, and there's a lot of dollars through the National Institutes of Health that's being funneled through the Tobacco Centers of Regulatory Science at the federal level that are starting to fund this type of research. So currently we basically just have descriptive studies documenting the fact that those with these comorbidities and mental illness are using e-cigarettes, among other things, including conventional products, at a higher rate than those without mental illness or substance abuse. But in terms of the longer-term interventional studies to assess, efficacy of e-cigarettes for cessation among this population, we don't currently have that science yet, but I do know that it is underway by several entities across the country.
Interesting. So, just from your answer, it sounds like the BRFSS is probably does not currently include a question on e-cigarette use. Is that correct?
So they included it as of 2016. So those data will be coming out this year. So they're not yet public, but state-level estimates should be available. And the National Health Interview Survey does have the questions as of 2014. But the questionnaire we typically use for mental illness population is the National Survey on Drug User Health, and they do not have that question, and they do not plan to do so for a few more years, unfortunately.
We have a few questions in the box here. One question that I think is interesting is just sort of about the demographic breakdown in e-cigarette use. Are there any racial or ethnic disparities that have been noted among youth using e-cigarettes, or any rural-urban disparities that have been noted in use?
Yeah, sure. So there are similar disparities in e-cigarette use. It varies by adults and youth. In terms of adults, it's very similar to the disparities we've seen for conventional cigarette smoking. And the reason is because most adult e-cigarette users are either current or former smokers. So you're going to have higher rates of use among lower socioeconomic populations, those with lower income, lower education. We also see higher rates of use geographically in the South and the Midwest. Higher rates among among men, higher rates among sexual minorities, the lesbian, gay, bisexual, and transgender population, as well as higher rates among those with other comorbidities related to substance abuse, as well as higher rates among those with mental illness. But again, for the most part, the trends among adults are going to follow conventional cigarette smoking because there's a lot of dual use. In terms of youth, it's a little bit of a different scenario. We've seen an unprecedented uptick in the use of these products that increased by 900% from 2011 to 2015. And the use was pretty much across the board, that most kids were using these products at comparable rates. We did see slightly higher rates among non-Hispanic whites compared to non-Hispanic blacks and Hispanics, and we think that that could be a result of access through socioeconomic means, and that kids from more affluent areas might have had more latitude to purchase the products, which can be fairly expensive if you have the larger tank-style systems. But for the most part, there's not a lot of marked disparities among kids. It's really universally used across the board, though we do see slightly higher rates among boys compared to girls, and again, non-Hispanic whites compared to other race ethnicities, and it tends to increase with age. So you have markedly higher rates of use among those kids that are in 9th through 12th grade compared to those who are going to be in the middle school demographics.
Great, thank you. There is a question about potential lung damage with e-cigarette use, and it seems that most of that damage would potentially come from the inhalation of aerosolized ultrafine particles and heavy metals that can potentially be sort of get into the very small airways in the bronchial tree. I know of some research that has shown, aerosolization of heavy metals with, for example, brake pad use has been shown to be harmful. What is the sort of cutting-edge research being done around this in e-cigarette use?
Yeah, so there's a lot of different studies that are being done in terms of both environmental studies as those assessing various biomarkers to assess what the actual impact of exposure to the aerosol is on actual humans, particularly kids. For the most part, the environmental studies have not linked the specific constituents to adverse health effects in terms of e-cigarette aerosol specifically, but we have identified several harmful constituents in the aerosol that has previously been shown to cause adverse effects. So those include things, as you've already mentioned, heavy metals, ultrafine particulate, particularly PM2.5, which is 2.5 microns in diameter or smaller, which can be inhaled very deep into the lungs. And the extent of PM2.5 levels that have been identified in e-cigarettes at some instances in products are just as high as the PM2.5 levels that have been observed for conventional cigarette smoke, including secondhand smoke. So we know that there's very high levels of particulate, and again, we know that it can be inhaled very deep into the lungs and cause complications. Another thing to consider also is that constituents in terms of flavors. And there's a lot of flavors that are used in e-cigarettes, and that's the primary reason that kids report using e-cigarettes. And these flavors, although some of them are approved by the FDA for ingestion, and that's the GRAS standards, generally recognized as safe, they're not approved for inhalation. And of course, as clinicians, everyone knows that the gut can handle a lot more than the lungs can. And so there's certain adverse effects associated with various flavorings that are used. The most notable that's received some attention in the media is diacetyl, which of course has been linked with bronchiolitis obliterans among certain worker populations at levels of exposure that are comparable to what you could get through using certain types of e-cigarettes in the long term. So it's important to note that there's really a lot of diversity in the products, and we do know a lot of comparability in terms of constituents such as ultrafine particulate, volatile organic compounds, tobacco-specific nitrosamines, among others that have been identified in the e-cigarette aerosol, but there's also some variability in terms of flavorings that are going to vary by the product, and those flavorings are not necessarily benign, and there are potential harmful effects in terms of respiratory disease and others that could arise from these various constituents. In terms of the science, we're currently at a point where we know that it's in the aerosol, and we know that those constituents are harmful, but in terms of linking actual use of an e-cigarette with these constituents to adverse health outcomes, we're not quite there. But there are some studies that are starting to be released from the past few years that are getting at that through smaller pilot-based studies and not necessarily the more robust types of studies that we typically need to make more pronounced determinations based on those health risks.
That seems like it would be particularly concerning for youth who are using e-cigarettes, since the vast majority of them are using flavored e-cigarettes. Is that correct?
Yes, I think you're absolutely right. And of course, youth and specifically infants as well, the lungs are still developing, and so the implications are even more pronounced for that demographic.
Yeah. There's an interesting question on how to dose nicotine replacement therapy for patients or people who are trying to stop e-cigarette use. And it seems like that would be difficult given the varied concentrations of nicotine that are delivered through the different mechanisms or through the different devices. Are there any guidelines that clinicians can use to sort of make some predictions about how to dose nicotine replacement therapy for these patients?
So the short answer is no, not based on the evidence we have. It's a very complicated issue, and it's complicated primarily by the fact that e-cigarettes are so different in terms of the product landscape, and you can have such wide variability in terms of the nicotine concentration in the product. And there's also the added issue of the fact that e-cigarettes aren't designed to wane down nicotine over time. With the nicotine patch, you have the 21 milligram and then 14 and then 7 milligram, and it's very clear cut that you can provide clear recommendations in terms of waning the user down. With e-cigarettes, it's a little more complicated because the user can modify the device themselves to change voltage and also the nicotine concentration, and they can also inhale a higher volume of the concentration over time to vary the hit of nicotine that they get. So it's certainly something that you could suggest in terms of waning down the nicotine levels. We do know that there's about 1 milligram of nicotine yield that a cigarette smoker gets per each cigarette. So there's about 10 milligrams in the cigarette itself, and they get about 1 milligram in their system. So if you were able to counterbalance that with about 1 milligram from the e-cigarette, it would be comparable. And so that's why when someone who smokes about a pack a day uses a 21 milligram patch, right, there's 20 cigarettes in a patch, so it's about comparable. But with e-cigarettes, it's a little more complicated, and there's a lot of variability in terms of the user themselves, but also the product they're using. And it's also an added complication that what's labeled on the product doesn't necessarily mean that that's the concentration of nicotine. And there are several studies that have showed that even ones that are labeled 0% nicotine actually contain nicotine, and those that are labeled with nicotine have significantly different levels than what's actually put on the product. And so there's now that FDA has jurisdictional authority and can regulate those products as of August, we'll certainly hope to see some declines in that behavior. But right now it's essentially a wild west in terms of what products are available on the market, including the extent of the nicotine concentrations, and that they don't match the labeling of the products.
That's very interesting information. There's a question that's been posed a few times about the proportion of adolescents who use nicotine-free e-cigarettes, but it sounds like from your response to the previous question that even products that are labeled nicotine-free are not often nicotine-free, and so perhaps the reliability of those data is in question.
Yes, so you're absolutely right. And so there was a study that came out of the University of Michigan using the Monitoring the Future data, which got a lot of media attention last year, and it found that 20% of youth reported using they reported using nicotine-containing e-cigarettes. So the implication was that 80% of kids reported not using nicotine in their e-cigarettes. And so my response to that is that this is self-reported data, and the focus group testing and other pilot testing suggests that youth don't know what nicotine is, let alone whether it's in their e-cigarette product. And so using self-reported data from kids to ask them what they think is in an e-cigarette is not an evidence-based practice. What we do know from the objective retail sales data that is available through Nielsen, the same people that track the manner in which people watch television and shows, they also track retail sales. And so you can assess the nicotine concentration on the label in terms of UPC and sales nationally. And what we do know from that is that 99% of the e-cigarettes sold through assessed channels from the Nielsen data contain nicotine. And so this idea that 80% of the kids are somehow finding 1% of the market share simply doesn't make sense. And so we know that the vast majority of these products contain nicotine, and that's the point. The manufacturer wants that in there because it continues to engage a future consumer base. And it also is the primary addictive agent. And so the data that we do know from the most objective sources shows that the vast majority of these products contain nicotine. Although we do know that some people are using non-nicotine containing varieties, it's mostly the adults who are going into the vape shops. We know the kids are not going to the vape shops because there's youth access restrictions that don't allow them to get in there. So the kids are getting the products from the convenience stores and gas stations and from friends, and the primary source of those is through the channels that are assessed through the scanner data, which shows that about 99% contain nicotine.
Okay. I was particularly interested in just the risk to young children from, tampering with or finding their parents or their family members' e-cigarettes. Is there, I don't think that there's any consensus about how we should counsel parents or e-cigarette smokers about how to sort of safeguard their products from young children, but it seems like that would be a very reasonable thing to discuss with our patients who are using e-cigarettes, especially those who have young children, that these things should be treated just like any other toxic household compound.
Yeah, absolutely. I mean, I think that's a valid point. I will say that, the poisoning issue, especially among that younger demographic, has primarily been because kids have ingested the liquid and been able to access it. And so it's really a common sense measure to prevent access to these products in the home and elsewhere. Federally, there was a regulation that was implemented last year through the FDA that implemented package restrictions in terms of how e-cigarettes and nicotine-containing products could be packaged and sold. So it was essentially a child-proof product packaging that was required for these products. And so that has been implemented at the federal level, but it has not been in place very long, so it's still in the process of being enforced. But there are some safeguards being done at the regulatory level, but that doesn't close all the loopholes in terms of potential access from kids. And so I think that, parents understanding the fact that this liquid is not benign and that there are inherent health risks, and that, kids have died. There have been deaths nationally as a result of ingestion, and that nicotine can be toxic at certain levels. And that can go in terms of not only the inhalation or the ingestion, but there's also potential complications from dermal exposure. So it would seem perfectly reasonable for a clinician to acknowledge this, including among adult smokers who may be using the products to quit. And if they're successfully quit using them, that's a good thing, but they also need to make sure they minimize potential harms, particularly for kids in terms of not only ingestion and exposure, but also secondhand aerosol exposure in confined environments.
That's a great point as well. We do have a question about sort of what the next iteration of an e-cigarette might look like. You've sort of shown the progression from the sort of types of devices that are used. Is there anything on the horizon or in development that you think will be sort of the next type of delivery system that will be available?
Yes, certainly. So there's a specific product that a lot of industry analysts, specifically those who make a lot of money on Wall Street, are putting their time and energy in, and it's called heat not burn. And that's the technology, and it essentially is a product that comes in the same pack as cigarettes do, so it would be 22 a pack, and it includes actual tobacco in the device. But the tobacco is heated, but not to the point of combustion. So the user still gets the hit from the tobacco, but they allegedly don't get the same harmful effects as combusting the tobacco. And so these heat not burn products have been tested very prominently in Asia and Europe, and they are doing very well. And the tobacco industry, including major giants such as Philip Morris Ultra and R.J. Reynolds and British Imperial, are investing significant amounts of dollars into the heat not burn phenomenon. They feel that these products will be the next coming of the electronic landscape, and that it's beneficial in terms of the fact that it continues to afford the user latitude to actually get actual tobacco, but it doesn't have those adverse effects of exposure allegedly as actual combustion of the tobacco. That being said, they're currently poised to test these products in the United States very shortly. The tobacco industry typically has test markets across the country. It's normally the same cities. There's a few in Wisconsin, Oregon, and elsewhere. So we expect those products to hit very soon. Industry analysts expect it to do very well. A few considerations on the heat not burn phenomenon. We do not know if they are actually heat not burn. Some would argue that it's just heated products and that there could actually be combustion that could occur with these devices. And there's also broader implications about the health effects of these products moving forward and their inclusion in separate policies. But for the most part, it would be the next generation of e-cigarettes. And it's to be seen if it will do well. Back in the 90s, they had the Eclipse product, which was the precursor of the e-cigarette, and it floundered. And all the companies took it off the market in 2005. And then e-cigarettes came back around in 2010, 2011, and they really upticked in popularity. And that was a combination of a lot of things, including the inherent novelty of the device in the youth market. So it's to be seen whether heat not burn will be the next coming. But I can tell you a lot of people, including the tobacco industry, are investing a lot of dollars and effort in that.
Interesting. We've had a few questions about sort of policy level interventions that might prevent e-cigarette use, one of them being a tax on e-cigarettes. And some participants are wondering how that might be implemented or what that might look like. I'm not sure if that's something you can speak to, Dr. King.
Yes, certainly. So the issue of tax is something that has to be broached very carefully in the context of e-cigarettes. So the bottom line is that we know that tax is the single most effective intervention for reducing tobacco consumption. The higher the price, the lower the consumption. We see large variability in the prices of cigarettes across this country, and that's primarily because of the variation in taxes. So it ranges from about 17 cents in Missouri per pack to well over $4.35 in New York State. And then some local jurisdictions like Chicago have taxes of like over $6. And it's no surprise that the places with the higher taxes have lower rates of use of tobacco products. And so we would expect the same to follow with the issue of e-cigarettes. But the problem is complicated by the fact that there could be a potential benefit from these products for conventional cigarette smokers. So a lot of municipalities are addressing this issue very carefully because you want the tax high enough to prevent youth use, because we know it's very effective at preventing youth use, and also taxes are very effective in terms of increasing price and preventing lower socioeconomic populations from accessing the products. And we found that they're particularly effective among those groups with lower income. So you want a tax that's high enough to prevent youth use, but also low enough that it's not on par with conventional cigarette smoking, right? Because if you want people to potentially use it as a sedation device, and in the future if it's proven to do so, you don't want price to be a disincentive for them to access that. So states are approaching it very carefully. There's a variety of ways that they're doing that. Some of them, it's just an outright tax on the product itself, a base rate, but for the most part, it's based on a certain proportion of the liquid. And sometimes it's the nicotine concentration, so it would be, say, 10 cents per milliliter of liquid for the device, or X cents per the amount of nicotine in the device. That being said, the tobacco industry itself has supported that latter approach in terms of taxing the liquid concentration. And they actually supported a policy in North Carolina that was about a nickel per milliliter. The problem with that is that if the tobacco industry is supporting it, it's probably not a good thing. I mean, they are adjudicated racketeers, folks. So, the bottom line from that is that the amount of tax doesn't equate to be that much when you look at the volume of liquid in the e-cigarette, particularly for the disposable devices. There's only, a few milliliters, if that. So you're looking at 10-cent tax on a product. It has absolutely no impact.
Sure.
So in the Surgeon General's report, we broached the issue very carefully. The language was tortured in classic bureaucrat form, but essentially what it documented was that, we know price is effective, but we still don't know the best strategies or the best practices in terms of where that taxation and price should be in terms of preventing youth access and, potentially allowing conventional cigarette smokers to use it as an incentive to quit. So the jury's still out, but currently the primary way that people are taxing the products is a proportion of the amount of liquid that's in the device itself.
Thank you. We have an interesting question about using the e-cigarette delivery system as a way to deliver aerosolized medications like albuterol, which I have not come across in my practice. But have you heard of this phenomenon, and is there any recommendation about what impact this might have on the medication or delivery of the medication?
So this is a really important issue, and it comes down to the fact that these larger tank-style systems can be modified by the user to accommodate essentially anything. And I can tell you that at CDC we have received reports of essentially anything you can put in viscous form is being used by people, from bath salts, heroin, caffeine, alcohol, among several others. THC is the most common that we've seen people put in as opposed to nicotine, and it's pretty popular among youth. We know a study out of Connecticut showed that about 20% of middle school e-cigarette users were aerosolizing cannabis in the devices. So we know that it's fairly prominent to use other things, and particularly other substances. CDC released a national study in December that found that about 1/3 of youth e-cigarette users were using some other substance besides nicotine in the device. So we know it can accommodate other substances, but the extent to which that's actually administered to the user is another story. And so we don't have the science yet to really assess the efficacy of the use of these products for delivery of other devices. Of course, the technology is very similar to what we've seen. So the nicotine inhaler, which is an FDA-approved device, follows a similar anatomy as an e-cigarette. And so there are some trials and other research that has shown that these types of products can be effective at administering medications. But in terms of the e-cigarette itself, we have, at CDC at least, have not received any major reports of people using this to accommodate things like albuterol and elsewhere. It's mostly psychoactive substances, and particularly illicit substances, beyond just using these to deliver nicotine.
Thank you. Yes, I'll have to ask my patients about that. Since albuterol inhalers have become much more expensive for some patients, I can see why they might turn to that as a delivery device. I think we have time for one final question, and we've had a few questions about the risks of e-cigarettes exploding or catching on fire, and wondering why this happens and how users might prevent this or use e-cigarettes in the safest way possible so they might not catch on fire. Any recommendations about that?
Yeah, so the fire issue is one that has gotten a lot of traction in the media. In particular, if you YouTube this, you can see images from all over the country and security footage showing these products essentially exploding in people's pockets and whatnot. And it's a legitimate concern, but it's a very small proportion of the products that this is occurring. So it's important to note that this is a very small minority of these products this is happening. And the reason this is happening is a variety of reasons. One is that these products weren't regulated until August. So it was essentially a Wild West in terms of where the products were produced. Frequently it was over in Asia. China had the primary market share in terms of producing these products, so there wasn't much regulation in terms of the devices themselves or the batteries. And so a lot of the explosions that are occurring are people using batteries and devices that weren't necessarily made for one another or were made in a fairly shoddy fashion. And so any time that you put a shoddy device in coordination with electrical voltage, that can always have bad things can occur. And so a lot of these explosions have just been the actual batteries themselves, which have overheated and exploded as a result of essentially manufacturer defects as opposed to actually the user modifying the devices. We also know that pressure can also exacerbate the likelihood of this happening, which is why the U.S. Department of Transportation bans people from putting e-cigarettes in their carry-on luggage. So you can take them on the airplane. You can't use them on the airplane, but you have to bring them in the pressurized area of the airplane because there were several explosions that were occurring of these devices in the underbelly of planes. So in terms of recommendations to avoid this, there's not much you can do outside of ensuring that you're using a product that is comes with its original charger, and that you monitor when you're charging the device and when you're using it, and you ensure that you don't increase the voltage to high enough levels that could potentially enhance the likelihood of the product exploding. But right now, the products are only recently regulated, and so there's a lot of new regulations that could go in place at the federal level, at least in the United States, that could mitigate potential harms. But otherwise, there's just such a broad landscape of the products, and especially the source of where they're coming from, that it's difficult to say, any one product is less or more harmful than another. But it really takes due diligence to just ensure that you're monitoring these products as you're charging them, as well as using them to mitigate any potential harms it could cause from the explosion.
Certainly.
And that's certainly reasonable advice we could pass on to patients, so thank you.
Dr. King, thank you so much.
Dr. King, thank you so much for your time, and this has been so informative and helpful. We really appreciate you taking the time with us today. And I'm going to hand it back over to Tabitha now, who is going to wrap up our session and give us a few housekeeping messages.
Thank you so much, Dr. Gagliotti, and thank you, everyone, for joining today's presentation. We certainly hope you found it to be an enjoyable learning experience. We'd also like to extend a thank you to our speakers, Dr. King and Dr. Gagliotti, for providing such valuable information. Their contact information is on the screen, and please feel free to reach out to them with any other questions you may have about today's topic. Again, today's presentation was brought to you in part by the National Center for Primary Care at Morehouse School of Medicine, a national resource supporting primary care professionals serving in underserved areas. So before we go, we do have another quick reminder about our upcoming webinars on Wednesday, April 26th and Thursday, June 29th. So please be sure to join us for those exciting discussions. We also want to get your feedback about today's presentation, so check your email later today for a quick evaluation about how we can serve you better in the future. Thanks again, everyone, for joining today's presentation, and we hope you have a great afternoon. Bye-bye.